Hello and welcome to Learning Thursdays. My name is Bridget Hartman DeCenzo and I'm your host today for Learning Thursdays. Today's presentation is the DSM-5 changes, what the addiction professional needs to know. And our presenters are Pat Lincourt from Oasas and Kevin Wadalovich from the Outreach Project. If you have any questions about Learning Thursdays, please feel free to email the Learning Thursdays email address, which is learningthurs@ny.gov. And if you're interested in earning credentialing hours, you should know that Learning Thursdays presentations are free and approved for 1.5 credentialing hours. After registering for each presentation, you will be sent a link for the broadcast, the PowerPoint, any associated handouts, and a credentialing certificate. Type or write in your name in the space provided on the certificate, and please be sure to send in the sign-in sheet to the address as indicated on the form. Your sign-in sheet must be on file for your certificate to be recognized by Oasas' credentialing unit. I would like to draw your attention to the evaluation link shown on this slide. To help us better meet your training needs, please complete this very brief evaluation. The web link can also be found in the email that accompanied this presentation. Now I'm going to hand the presentation over to Pat Lincourt.
Hi, thanks, Bridget. I'm Pat Lincourt. I am the Director for the Division of Practice Innovation and Care Management, and I'm here with Kevin Wadalovich, who I'll let introduce himself in a few minutes. We're very pleased to have him with us to talk about the DSM-5. There's been a lot of interest in the field about the DSM-5, so we're pleased to be able to provide this training. Oasas is accepting as a diagnostic format in the regulatory for regulatory compliance, the DSM-4 or DSM-5 taxonomy until January of 2015. On January 2015, we'll expect that programs use the DSM-5. So on that note, I'll let Kevin introduce himself.
Thanks, Pat. Kevin Wadalovich of Outreach Project in New York City. I've been in the field since 1981. I also am a trainer at Outreach Training Institute, which is a CASAC training program in New York. And hopefully what me and Pat will be doing is talking you through the DSM-5, especially specifically for the what the addiction professional needs to know. And with that, we're going to start moving forward on the slides. And I always like to start like, why should you care about this? And why should we care about the DSM? Why is this thing used, and why do we use it? For several reasons. One is it in the United States is one of the primary diagnostic tools for mental disorders in the United States. And because of that, certain things flow from that. One is we literally put labels professionally and personally on folks in terms of this is a person who has this kind of thing going on with themselves, whether it's a bipolar disorder or a person with schizophrenia or a person with addictive disorders of different types. And there's pluses and minuses, of course, with labels. We always say people get labeled also with a stigma, but one thing I always think about is if you had something going on with yourself, would you want to know what it is? And so we go to professionals sometimes for labels in terms of tell me what this is, so now I am empowered and I can learn more about it and so forth, and learn about prognosis and so on. And from labels, of course, and from a diagnosis come treatment decisions in the moment or in terms of long-term treatment decisions with people. Certain disorders we know are more amenable to certain types of treatment, or else we don't treat people who have a certain kind of diagnosis this way because we know it is not helpful. So it helps us make decisions. Reimbursement, of course, is always another issue. So I always say people don't go and get treated for drinking cans of beer. They have to and won't get admitted to a Oasas licensed treatment program for drinking cans of beer. They have a alcohol use disorder, they have alcohol intoxication, et cetera, and that is the basis also by which insurance companies and Medicaid, et cetera, will reimburse for treatment of a disorder, something wrong with a person. Another factor which I think as clinicians we often don't think about is things like the DSM and the ICD we're talking about later are really used for research also. So when they want to research particular things that are happening in a population, they don't say, well, let's research people who are anxious. right? They don't say it's people who are sad. They say, well, we want to research people who have a particular thing wrong with them, such as an anxiety disorder. Well, what kind of anxiety disorder? People are sad. Well, what kind of sadness? We're talking about a clinical depression, or what kind of depression? Is it organic depression? Is it a dysthymia, etc.? So there really needs to have parameters when we do research around the kind of folks who would go into it and who's the best candidates, if you will, for that. Also, from diagnoses comes pharmaceutical development. We know this, and I think people have said, wow, this, when they have a new diagnosis, suddenly they have, or eventually they have, a new medication. And yes, because in terms of reimbursement, in terms of things that pharmaceutical companies are targeting, it is diagnoses of different types. And so what we'll see is different medication developments that pursue diagnoses as well. So that's another, if you will, thing that gets directed by us having something like the DSM, or again, we'll talk about later, the ICD. And literally statistical collection. How many folks do we know in this country, from a public policy point of view, have, for instance, not just anxiety, but post-traumatic stress disorder? How many people not just have psychotic disorders, but are suffering from schizophrenia? That helps policymakers, first of all, understand the nature of the beast, understand the prevalence of something happening in a given population, and that's a useful thing. But again, you got to have a definition of that, and that's why we have diagnostic tools such as the DSM. A bit of history and background of the DSM, and we can go back very far, if you will, in terms of diagnoses. One of the things I always found is, have you ever noticed that whenever we talk about descriptions of different things, it starts with the Egyptians so often? My sense is always, they have the writing on the wall literally, and so we start hearing people talking about it's on the Egyptians. And yes, the earliest descriptions of mental illness were actually in hieroglyphics back in ancient Egypt. But in terms of classification, we saw that actually in India, in Ayurvedic medicine, where they talked about people having various, what we now call mental health disorders, but it's based on demonic possession. So the fire demon, whatever is showing symptoms in this person, will probably be mania or something like that. But that's how they classified it then, obviously, in terms of they didn't have clinical understanding of the brain and so forth. Hippocrates, coming back to the medicine domain, really started first classifying mental illness in Greece, and he had, I believe it was 6 or 7 different categories of different kinds of mental illness. And then we'll just go along quite quickly on fairly perhaps the history, but the idea of there's been really an attempt to classify various kinds of illnesses, not just a mental illness, but also medical illness in different ways. And the challenge with that always is that, especially in earlier times, we had less communication, less between different cultures, between different countries, and literally different parts of the countries. What people called a medical or mental health disorder, they had different languages and names for it, literally, so that there was really no common way of describing something. The first attempt to really put medical disorders into some organized ways from the plague. So they were trying to classify causes of death, and a lot of times they found that you go from neighborhood or areas, they would classify deaths by symptoms. So someone had severe cough, they died of cough. They died of the fever, they died of the convulsions. Now, we know that sometimes those are just symptoms of a particular disease, and that was the attempt to say, well, how many people have these diseases actually, as opposed to symptoms, which they're saying is the name of the disease. And so they really tried to do that in the early 1600s in England. So that was a real first kind of organized attempt to do that, again, around medical issues. And it was just useful from a point of view of public policy, understanding public health issues and where resources and concerns should be directed. Now, this is something that not just obviously England, but other countries were concerned about, and they made all these different attempts, and they really started talking between countries about how do we go with the names of these things together, so that we understand that people from France who also have these illnesses have the same ones as people from Germany, England. Even again, we have different language and different names for these things. And this was an ongoing kind of thing. They actually had international conferences on this to try to create these kinds of conversations and, again, a common language around this. And in the middle of the 20th century, they really started to have some consensus, if you will, around this. But then what comes, of course, in the middle of the 20th century is World War II, of course. But out of World War II, I always said there's 2 things that were perhaps very helpful. One is the United Nations, but the second thing is the World Health Organization. And the World Health Organization said, well, we really want to organize the world health concerns, and again, because of communication differences, but also because people were traveling more and more between countries, between cultures. We really need to have this common language, first of diseases and how people die, etc., and also injuries. And out of that, one of the first tasks of the World Health Organization was to create this, what we now call the ICD. They didn't call, at that point, called it the International Classifications of Diseases, Injuries, and Causes of Death. Again, to create this common language. Now, why do they need this? And the example I would give is, imagine you're a clinician, a medical clinician in Japan. And there you are in some suburban area, and in walks a person who only speaks Icelandic. And so you're not understanding what they're saying, but they show you their toes, and they have this discoloration and so forth. As a matter of fact, you don't know this, but the guy is actually showing you his medical records, which unfortunately is also in Icelandic. And he's pointing down to you, and he may be saying, Sakuruski, Sakuruski, and you, of course, have no idea what he's talking about since you're Japanese speaking only, and they are Icelandic. So you might or might not be able to accurately diagnose that before something even worse happens to that person, and maybe not. But maybe you find somebody who speaks Icelandic in Japan. I have no idea how frequently that happens. But then, we find out what it is, and you as a Japanese clinician say, oh, you call that? We call this tonyo-byo, which is nice. Then you start treating that tonyo-byo. Now, of course, you and I may not know what that is yet, right, if we don't speak those languages. Now that person actually gets not only medical records from Iceland, now they have medical records from Japan. And here they come to the United States, where we speak English. Now they show up in your medical facility, and they have both sets of medical records, and he's telling my Icelandic patient says Sakuruski, and he's showing you two sets of records that say Sakuruski and tonyo-byo, and you still have no idea what's going on, right? That's the challenge. And people have certain common disorders in different languages, cultures, and so forth. And the idea is, can we create a language for all this? Now, hopefully you would figure out at some point it's diabetes, but also what type of diabetes is this? This is a certain type of diabetes, and as a clinician hopefully would, before bad things happen to that person again, they would be able to figure that out. So that was the idea of let's get a common language, and the common language is what across so many languages and cultures is letters and numbers. And so the ICD was created the concept of let's have these various diagnoses put in specific letters and numbers. So they said, well, maybe this is E11 diabetes with E11, I forgot what it is, F12 or something, which is with peripheral neuropathy or something like that. So imagine they walked in with those records and they had E11, F12 right from the get-go. You can more quickly and efficiently address and diagnose and treat this kind of disorder. So that's the kind of the principle, if you will, of having diagnostic codes like that. Good idea. We all decided. Now, the United States, our first attempt, if you will, of diagnosing things we might call mental disorders, etc., was in the census. Now, a whole bunch of you folks have probably taken censuses at times or seen the forms, and they ask you questions about how many people in the household, at what age group, certain demographic profiles, and so forth. Well, on the 1840 census, they actually asked you how many people have idiocy, which is probably our equivalent of what we, actually, I would say, used to call mental retardation, and with Dsmv we would now call intellectual disability, and then insane, which was probably a whole spectrum of things. People with psychotic features, which probably included people what we now call schizophrenia, in bipolar episodes, etc., etc. They expanded that subsequently in following decades to include other kinds of what we now call certain kinds of mental illnesses, but even some which weren't. And one is epilepsy. People were asked about epilepsy as a mental disorder back then, and also a particular disorder specific to syphilis, which involves muscle control, called paresis. And I always found the interesting thing is our friend alcoholism is even in the 1870s there, as they called dipsomania, wet brain, which is probably something to do with alcohol-related brain dementia of some sort, which really speaks to how frequently, even back then, that issue was there in the population. Now, some of us probably took a high school or college, we learned about the Industrial Revolution, and one of the things that happened with that is people were going more from rural areas into the cities and working in factories. And when we had people, especially with severe mental disorders, we had the issue of who's going to take care of them. If you were living on a farm, you might have somebody be able to watch that person. They may even have some functions around the farm, like bale the hay, take care of cows, and so forth, simple jobs that someone perhaps could do. Once we started going into the urban areas, and there were people going to factories where they were there the whole day, they weren't going home, and we had more sophistication of negotiating urban environments. We had issues with who's going to take care of certain people in the family. And that's where we saw, with other things, the growth of what we then call the insane asylums, mental asylums, whatever phrase we want to use. Now, when people are coming into were being asked to take care of these folks, well, what do they have wrong with them was the question. And we had to classify them because I think we also know, as we work with mental health facilities, that you don't want to put certain types of diagnosis with other types of diagnoses because they don't interact well, and it creates a management problem. But also, how you treat different individuals inside of those settings would be quite varied as well, even back then, what they might use. So they really trying to create classification systems around that, simply for purposes of, again, management as well as treatment. Now, what happened is we didn't have any organization around that, so different asylums, different locations had different ways of classifying individuals, and that went on not only in the urban areas and the hospitals, but also even in the military, where you had folks either presenting or developing various psychiatric disorders, and how do we classify them in the course of our treating and servicing them. And we had problems with that because, again, there was no organized, consensus-based way of diagnosing individuals around these. The American Medical Association tried to put out a guideline, if you will, around that, which was really hospital-based typically, around how to work with classify individuals. But unfortunately, other systems inside of there, including various systems in the armed forces, those in the armed forces know there's the Army way, the Navy way, the Marine way, the Air Force way, and the right way, as they used to say in the jokes. And so they had their own systems as well. Chaos reigns, right, in terms of these kinds of things, because obviously some people get transferred from the care of one group to another group as well. And so amongst this, we had this kind of confusion going on, and which is, again, exactly why the ICD was being developed in the same premise, is we got to create this kind of classification system that everybody can agree on and work off of. Now, so as I mentioned, in 1948, the World Health Organization put out the first version of the ICD, and they presented it around the world, obviously, in terms of different nations. Here's a system. Not all nations, not all cultures really bought into certain kinds of aspects of it, including the schools of psychiatry. So, and the criticism of, well, we don't have that kind of thing, we call it that, or else, and those who work in the mental health background and history know that there had even been different schools of psychiatry and mental health. You had the Freudians, you had the behaviorisms, you had the third wave was emerging in psychology and psychiatry as well there. So even amongst that, you had differences. So from there, you had, in certain countries, in certain parts of the world, they said, well, the ICD is useful perhaps, but we also have even some supplemental diagnostic systems, which were, again, specific to certain parts of the world and certain countries and cultures. Now, in the United States, we also had some disagreements and problems with it as well. I always think of this as, imagine the metric system we didn't like as well, so we had our own system in that. So the American psychiatric system at that point had a variance, if you will, on the ICD, which had come out, and that is really the impetus of our DSM, Diagnostic and Statistical Manual. And it has evolved, as has the ICD, with our understanding of different diagnoses, our understanding of different conditions. Some come in, some go out, some really kind of fluctuate and merge around in terms of names and nomenclature and so forth. And this is a kind of an ongoing kind of process that has been going on for quite a long time. And in 2013, May 2013, came out the new DSM-5. By the way, one thing I point out, have you noticed DSM 2, 3, 4, etc. are Roman numerals, and they actually have a non-Roman numeral number 5, and people sometimes say, well, is that a mistake? No, it isn't. The thinking behind that is, and you think of your software, you can think of it the same way. They anticipate more changes without these major revisions coming along the way, so that they might have sections that they change based on our understanding of brain science, using genome research, and so forth. So they might have a DSM 5.1, 5.2, just as you have various editions of software. You have 10.2, and then you get the updates 10.3, etc. So that's the thinking around that. One of the things you'll see in DSM-5 specifically is that it's really also an attempt, and they were very overt about this, an attempt to really align themselves much more with ICD, with the World Health Organization categories. And actually, those of you who have the DSM-5, you will see with the codes of the DSM-5 next to them, you will see literally the ICD codes, or what they would say is as close as possible to the ICD as well. And there's a whole bunch of reasons for that. One is certain settings have to use ICD coding, and that's by policy, but also literally international treaty. We have to use ICD codings. And just also, again, we have so much cross-cultural research done. Clinicians from different cultures go back and forth and so forth. So it just makes more and more sense for this to be aligned along the way much closer. Some of the stuff is literally language differences. I always say violins and fiddles to different people may have the same meaning or slightly different meanings. And that's one of the things you'll see if you ever look at the ICD versus the DSM-5 is there's some quite a bunch of similarity. And other times, maybe there isn't that there. So again, quickly, how do they get to diagnoses? How is there they develop this kind of consensus? It's a long and tedious process, as one might imagine. And how they first started with, and here I'm talking about DSM-5, they created work groups, and if you looked at those work groups, they look very similar to what the chapters, if you will, in DSM-4. And that's very much where they started from in terms of saying, all right, here's the various groups that we're going to have, but they certainly tasked the folks in that, listen, you do not have to look at diagnoses based on categories like this, but this is where we'll start. They were looking, if you will, for experts from these kinds of areas. Now, one of the issues that comes up on this is, all right, we're going to have experts develop these categories, and all right, what are they going to do? What's their task? Is not to advocate for a particular diagnosis, but really to be research and medical experts about, is there enough evidence for these things as a standalone diagnosis based on a variety of factors, including research that's already developed in the field, but also sometimes even some independent research they do. Now, that's a harder task than you can imagine. The example I always give is in our own field of addiction. I hear people all the time talk about codependency. And this person's codependent, et cetera, and I ask people, what do you mean by codependency? Because we throw that phrase around. And then you hear various people talk about, well, they have this, they do this, they enable, and so forth. And I challenge them as well, when do they enable? Is that because they're codependent or because they're financially vulnerable? Because they have certain value systems that compel them to still be with that person. So, they don't throw the bum out after they're drinking. They're codependent. I say, well, that's nice, but maybe they have no options. Maybe financially they don't have any options. One of the examples I give in one of the clinics I oversaw, we had a number of Polish women who were in the track we called significant other. Now, they weren't leaving these very active alcoholic individuals, and of course what some people may say is, well, why don't they divorce them? And one of the things people didn't understand sometimes is that, well, they're all Catholic, and in Catholic culture and religion, you do not divorce people. There's also an economic vulnerability because they were there in this country and perhaps they knew no one else. So where are they going to go to? Now, are they codependent therefore, or just simply folks who have religious beliefs and are economically vulnerable? And that's the idea of how do you decide if something really is a standalone psychiatric disorder versus other factors that go into the considerations. And that's why, by the way, we don't have codependency in the DSM-4 or 5. And there was a proposed codependency diagnosis, actually, from Tim and Cermak. So it's not as easy at times to do these kinds of things. So what these committees do, and by the way, people always say, well, gee, these folks in these committees, there's a financial interest, right? Because I said there's pharmaceutical development follows this, insurers can decide what to bill or not bill based on this. So there was a financial vetting process around the people who are in these work groups, which I can't go into, around that to try to minimize that kind of risk. But these are the experts in the field in these various categories, and they are called upon by various parts of the mental health culture, if you will, to lend their expertise in different ways. So what they did do, of course, is always look at the existing literature to say, is there enough evidence for this as a standalone diagnosis? The other thing is, they looked at existing studies, but also when we said studies, it wasn't just in psychiatry and mental health. It was also, and we have so much of this now, brain studies, neurology studies, and the human genome studies to help us understand what is going on. And one of the things they found is that, for instance, some of the things that might be behavioral expressions of a condition may have the same place in the brain, even though it looks like a different expression. So think of gambling versus someone with a substance use compulsion, if you will. Does that not look very similar? When someone's on a gambling run, get it drug-free, and it's almost like a cocaine run, isn't it? In terms of there's a lot of agitation, they're on a going process, and they can't stop, et cetera, et cetera. And people sometimes talk about the run in the same way. Well, is there the same part of the brain firing would be one of the questions around that. And that's what they found, is that certain things don't use just that as an example, certain parts of the brain are active with certain kinds of disorders, but again, they express themselves in different ways. So that they decided that, gee, some folks with post-traumatic stress disorder look less like other kinds of anxiety disorders, but they look like some other kinds of things. And people with obsessive compulsive disorder, for instance, have a lot of things similar to people with air pulling disorder, trichotillomania, actually, in terms of where the brain fires, and also in terms of genetics, where things come from. The other thing they did as well, besides looking at those kinds of studies, is also they said, well, we just don't know. And there was some ability to actually do field trials in community centers, medical facilities, and so forth around different patients. And again, to literally see if there can be a consensus on a diagnosis. So imagine we had this disagreement about codependency, and we said, all right, here's the criteria for codependency. Let's get some people that perhaps some clinicians identified as codependency, and let's see in a field trial if some independent clinicians could diagnose them the same way. And that was the idea of doing things like field trials, is to see if they really stand up on their own. And again, this was created as a research agenda years ago by the American Psychiatric Association. The other thing they did is that these work groups were of a certain size. You had to make them small enough to really make them manageable and efficient and workable. But they also had behind them, if you will, various advisory groups to, if you will, knock your ideas around with. So you had thoughts about, we're thinking about this is a diagnosis going in this direction, cultivating it, if you will, in a certain direction. What are you folks who are in advisory capacity thinking about that? And so they really had other experts to bounce off ideas. And I know they really making an effort, as they really try to do in the DSM-4 as well, to have cultural experts in there as well, because that's very often where we see sometimes misdiagnosis and confusion around that. The other thing they did is they literally posted their ideas around this on the internet. So I remember, I've been tracking this for quite a while, and so if you went to dsm5.org, before the DSM-5 came out, for years before, they saying, here's the proposed diagnoses, and you folks anybody out there want to give us feedback on these things, give them to us. We're really eliciting these things. I hope you all contributed to that. I know I did, but they literally had over 10,000 responses around that. Now, so then these various work groups came up with their ideas, their, if you will, proposals. They then had to go to the American Psychiatric Association's DSM-5 general committees, and they were looking at various kinds of things. One is there enough research, again, to support these proposed diagnoses or continuation of the diagnoses or these proposed changes. They also had a committee for, well, what's the implications of this in terms of public health? And also a committee for in terms of law. Because all these diagnoses really have major implications and challenges when we have changes around things. People are going to change their labels. What becomes eligible for reimbursement changes. Legal defenses start changing as a result of these things. So it's a big deal whenever this kind of mechanisms gets set in place. One thing I'll say, and we can't go over the various mental health disorders, obviously, but some of the things that were just as an example, if you will, some of the changes is, and some of you may notice already, certain things like Asperger's, which was considered a standalone disorder in the childhood disorder category, which is gone as well, is now been merged into autism spectrum. Now, why is that? Well, one of the reasons they felt was that Asperger's is actually a kind of a manifestation of the same thing we see with autism, but again, it just expresses itself in a, what we might call milder. I don't think everybody would agree with that, but the idea is not as pronounced and profound as we might call traditional autism, images of autism. And so what they really visualize this as a spectrum. Think about cancers, think about Alzheimer's. You have stage 1, stage 2, stage 3 thinking around this as a spectrum. And that's the idea with DSM you're seeing more and more, is they went much more into kind of this spectrum mentality, and what we then called Asperger's would probably be considered autism spectrum disorder in the mild version. That's, by the way, a preview when we get to substance use disorders as well. We're going to think that way. Various somatic symptoms. We used to use language around the person somaticizing their hypochondriac and so forth. Well, they got that language out of there, and they start talking about somatic symptoms, and then they'll talk about subtypes, perhaps, with this kind of feature. But they really wanted to kind of narrow these things down in terms of labels, but also widen it from the point of view of spectrum. And by the way, there are less diagnoses in DSM-5 as opposed to DSM-4. That was one of the things people said, gee, DSM, the original DSM, then we had DSM-2, 3, and 4, more and more and more diagnoses. Does everybody have a mental health disorder? Well, they actually have less labels, if you will, but that doesn't mean in terms of diagnosis you're going to have less people labeled, because you might have mild, moderate, again, severe versions of these kinds of things. And then, of course, what's relevant to us is, and some of you may have heard about this already with DSM-5, we're not going to have these separations around substance abuse versus substance dependence. We're going to have this, if you will, spectrum, what we now call a substance use disorder. And with that, I'm going to pass this over now back to Pat.
Okay. Let me advance here. The multi-axle system in the DSM-5 has been removed. So what does that mean? That all 5 axes were required in DSM-4 for a full diagnosis. And they weren't always used, and sometimes they were used kind of forma, but without any specific information tied to particularly Axis 5. So now there will be documentation of what was Axis 1, 2, and 3, but they'll be documented in a more integrated way, so that there is a primary diagnosis. Personality disorders are still included in a diagnosis, as well as medical disorders. But Axis 4 and 5, and specifically, are not going to be coded at all. So it's not that clinicians are being asked not to pay attention to the psychosocial kind of issue, the context for the disorders or for their functioning, but it's to increase the kind of uniformity where people, or the integration of the diagnosis. So Axis 4 and 5, there's WHO recommendations to consider in the context of functionality, and the World Health Organization that Kevin talked about earlier does have a functional assessment kind of rubric that clinicians can look at and integrate that kind of thinking into a diagnostic picture, but they won't be asked to code that on the multi-axle system. So it's important that clinicians do continue to list medical conditions that are important, especially to the understanding of the individual's mental disorder. So if there is if you have a substance use disorder that you're diagnosing and the person has also high blood pressure, those disorders may be connected to each other, and something that should be included in a diagnostic formulation, so that particularly as we talk about integrated treatments, that the diagnosis is comprehensive. There also is in ICD-9 V codes, and in ICD-10 they've transitioned to Z codes, but they look very similar, that can identify factors that influence health status. And these may be more important to add to a diagnosis. Things like poverty or homelessness are included in those Z codes. So the World Health Organization Disability Assessment Schedule, that's that functional assessment that I had referenced before, is being considered for Axis 5. It is available online. It is pretty complex. There's a lot of interchanging parts there. It makes the personality disorder chart look very simple. So what about people who do have more than one diagnosis? There is a principal diagnosis that should be coded first, and so that is, if you're working in an inpatient setting, the condition that is mostly responsible or chiefly responsible for that person's admission. So if somebody has a bipolar disorder but they're being admitted because of their cocaine dependence, and that was the chief cause of their admission, the cocaine disorder would be coded. For outpatient, again, the chiefly responsible for attention and treatment. One of the things that is important about this is it really gets us as behavioral health clinicians to focus on that presenting problem. What is the problem for which or condition for which the client is presenting to you for treatment, and to think in those terms, because that helps to guide also the treatment planning. So there was a lot of speculation early on, and I know, Kevin, if you were watching it closely there, about personality disorders in the DSM-5, and I think a lot of people who have been in the field for a long time and have found personality disorder diagnosis to be interesting, have been very intrigued by where the DSM is planning to go with that. If they ended up kind of defaulting back to the same personality disorders that are found in DSM-4, but there is some hopefulness, I think, in some of what their thinking was in terms of looking at specific behaviors and specific traits for health. So I think this could be a whole Learning Thursday by itself in talking about what could be coming. We're not going to do that today because we want to focus on SUD. Some substances have been deleted, and one of them that's important to us is polysubstance dependence. All substance use disorders will be coded with the substance, and that is part of the reason, at least, for why that is.
Back to me. I make one comment about polysubstance dependence. I think that's an example. That's one of the things I complained about in the DSM-5 feedback, by the way, online, is the clinicians being compelled, if you will, I think, to identify the drug that they're doing. And I think those who work in the field long enough know that sometimes we have folks, what drug are you using? I don't know, whatever you give me, I'll use it. And when I smoke my weed, I'm drinking my beers, and then I get in trouble. And well, then how do you tease out, if you will, whether that's alcohol or cannabis related or, et cetera, et cetera. They decided to get rid of that, though, and I think we'll see how that plays out. Just moving on a little more further on to just some ideas around DSM-5. They have in the DSM-5 what they call an emerging conditions section, and I think the way to kind of conceptualize this is think of on the on-deck circle for the ball game. It's not these things they call emerging conditions are not DSM-5 diagnoses, and as such they're not recognized as diagnoses yet. They're ones where they think there's evidence that these kinds of things really might exist, but they need more research to really substantiate them. So, and they, with further consideration and research, they may change the specific diagnoses as well. But there's certain ones that seem to resonate, both from the point of view of research and clinical experience, that really might be a diagnosis. Actually, the one I found as I go around this talking about this is people have what one proposed as self-mutilation disorder, where people are cutting themselves and hurting themselves without the intent of committing suicide. And so that's one actually that's being proposed, but there's a number of different ones. The one from a point of view I think of us folks in addiction is intriguing is they call it internet gaming disorder. There were actually a number of different what you might call screen addictions were thought about in terms of, again, you work in our society now, you live in our society, you see a whole bunch of people doing things with their screens, don't you? Whether it's on the phone, they're stuck in front of the television, they're not playing with their friends, they're in front of the console doing this, doing that, etc. So the idea though is where do we have the most research around especially particular screen disorders? And what they found was what they called the internet gaming disorder. And the idea here is, again, if certain people are literally putting themselves in front of the playing these internet games to the point of perhaps clinically significant impairments. Some of you maybe can relate to this, especially if you have kids, in terms of they're not socializing, they're not doing various responsibilities that they're supposed to be doing, but as well, they also, and this is, by the way, it's not just a question in the United States. This has been considered a fairly large issue in parts of Asia, where they have various parlors, and they've been talking a bit about this as well. There's also been some real research on when folks continually get involved in this stuff for an extended period of time, what happens to the brain. And they're really starting to track literally some perhaps differences in the development of gray versus white brain matter. And actually, I just read something 2 weeks ago, American APA DEA had a meeting a few weeks ago, and somebody presented a paper where people who met this criteria, proposed criteria of internet gaming disorder, they had deficits in terms of hearing capacity development. Now, again, that's one piece of research. That doesn't necessarily mean it's going to have a disorder. But the idea is, when you have these emerging conditions, the hope is that we're going to start doing more research around this to see if these things exist, or how maybe it isn't exactly how we thought it is, but something different, but a version of that. So that's the thought around that. And basically, I just talked about over these slides that you're reading now around these things. But again, it's the idea of gamers playing compulsively to the point of clinically significant impairment. I always thought about the people online doing the online poker. So is that going to be pathological gambling, or is that going to be an internet gaming disorder, or is it, I don't know. Again, these are the kind of questions they have to cull out, if you will. And I just kind of talked over this in terms of the slide. But just to move forward with it, one thing we didn't mention here in terms of another proposed diagnosis, which is of relevance to us, is fetal alcohol syndrome. I hear people all the time talking in our field about fetal alcohol syndrome. There is no agreed upon diagnosis of what fetal alcohol syndrome is from the point of view of the DSM. Now, I know people say, well, there's a certain physiological features in terms of the forehead size and in terms of the separation of the nose from the lips, the presence of intellectual disability, and so forth. But there is no agreement on what that is. So up to now, and including now, what you've had is people who manifest that symptoms we call other neurological developmental disorder or things like that. So one of the things they're going to try to do is try to get some clarity on this, because again, there's evidence, we think, that children exposed in the womb to alcohol, a certain subgroup of these have some particular developmental issues. But again, until we do enough research on this, we don't have the common language, and so it's not there yet. To be continued. Now, this is the one I found when I talk about it, many people can relate to and say amen to. And so one of the emerging conditions is also caffeine use disorder. So as you're watching this, you might be doing your own personal inventory of your loved ones as we go over this. So you have caffeine use disorder, perhaps. I propose that we have three. Persistent desire to cut down or control. Now, does this now already sound like addiction, right? Continued use despite negative consequences. Withdrawal syndrome. You know what that one is, the headaches, right? Taking more or longer than intended. Failure to meet major role obligations. Again, this looks like it comes right out of other substance use disorders, right? Tolerance. Give me the Vante instead of the Grande, please. And abnormal time spent in drug pursuit or recovery. Where is Kevin? He's supposed to be here. Oh, he's down getting the coffee. Things like that. Again, but you must have clinically significant impairment before. We never self-diagnose yourself. I hope we all know that. But the idea of you got to have clinically significant impairment with these kinds of symptoms around this. I'm sorry, missed one, which is also craving. Is it time to have one now? What do you think? And that's the idea of this. And we'll get back to craving, actually, with other substance use disorders as well. And with that, actually, I'm going to turn this over to Pat, and we'll be talking now about that.
Okay. So we're going to spend a little bit of time talking about the criteria for substance use disorder in the DSM-5, which I'm sure is what you have been waiting for. There is in Part 822, a requirement that you meet the criteria for DSM criteria for substance use disorder. And the big change, obviously, here is that the DSM criteria gets away from the idea of abuse and dependency, and substance use disorder now has three severity levels of mild, moderate, and severe. So the Oasas will accept either DSM-4 or DSM-5 until January of 2015. But at that point, we're expecting that you have trained clinical staff, and this is one of those efforts to get some training out there on how to apply the DSM-5 criteria. So substance use, that in the DSM-4, that maladaptive pattern of substance use leading to clinically significant impairment or distress as manifested by one or more of the following within a 12-month period. And that 12-month period is something that clinicians needed to pay attention to, and sometimes didn't. I think that was maybe some of the thinking that kind of went into this, that there was also a recurrent substance use resulting in some major role obligations not being met, or where it was physically hazardous, driving an automobile or operating machinery, and recurrent substance-related legal problems, use despite persistent recurrent social or interpersonal problems caused, and the symptoms never met the criteria for substance dependence for that class. So that was the substance abuse from the DSM-4, and though that whole class has been rolled into substance use disorder, and what would be seen now as mild substance use disorder, but with some, some additional challenges, I think, for us from diagnosing. And I think that some of the early field testing has shown that there would be less, by eliminating substance abuse, we will see less diagnosable SUD. So substance dependence in DSM-4, that maladaptive pattern again, and always that need for clinically significant impairment or distress. So, and again, that 12-month period. So for substance dependence, that's where tolerance withdrawal became, our defining kind of characteristics, the physiological dependence on the substance. The characteristic withdrawal syndrome for the substance. And in 5, one of the interesting things that I think is very helpful is that they've included withdrawal symptoms that are specific to each of the substances. But DSM-4 substance dependence, the same or closely related substance taken to relieve or avoid the withdrawal symptoms. So that was another criteria for withdrawal. Taken in larger amounts or over a longer period of time, or that persistent desire or unsuccessful effort to cut down. And then a great deal of time spent in activities necessary to obtain the substance. So there are lots of examples of that I'm sure you can think of for people's lives. Important social, occupational, or recreational activities given up or reduced. And then the use of the substance, despite the knowledge of having a persistent or recurrent physical or psychological problem that's caused or exacerbated. So examples here, current cocaine use despite recognition of cocaine-induced depression. So the person is aware that depression is caused by the crash of after cocaine, but continues to use it, or continue drinking despite that an ulcer that's made worse by alcohol consumption. And then there was specification for physiological dependence. So if you had the evidence of tolerance withdrawal, that's a specifier. And so either tolerance or withdrawal were present, and then without physiological dependence. So that you met, the criteria, but did not meet either tolerance or withdrawal. And then core specifiers, early full remission, at least 1 month and less than 12, with no criteria for dependence or abuse being met. Early partial, at least 1 month and less than 12, with 1 or more criteria being met. And these get a little bit consolidated in the DSM-5, and then a sustained full remission where none of the criteria for dependence or abuse was met any time during a period of 12 months or longer. And then a sustained partial remission as well, where the full criteria for dependence not met for a period of 12 months or longer. So there's a core specifier also in DSM-4 in remission on agonist therapy. Somebody who's on an agonist such as methadone, who are not abusing the substance, and in a controlled environment. So people who were particularly in a jail or prison environment, a residential program where access to substances has been restricted. So the remission criteria only applied to dependence and not abuse. Abuse was often recognized as an on-off phenomenon, so where you would have maybe a period of use that was that you met the criteria, then maybe a period where you didn't. So it wasn't considered a remission necessarily. It may never recur in a person's life because and I think that was fueled by the thinking at the time that this may be more situationally induced and not as much of a brain kind of involvement. So as of May of 2013, with the advent of the DSM-5, the changes that occurred are significant in substance use disorder. There is no more abuse, no more dependency language at all. So it's seen, like other disorders in the DSM, it really follows that continuum that Kevin was talking about earlier in terms of the autism spectrum. And all of the diagnoses actually are being seen in this way, so that you may have a mild presentation, a moderate, or a severe presentation, but it's really the same underlying disorder. So we have now a problematic pattern of substance use that leads to clinically significant impairment or distress manifested by at least two of the following occurring within a 12-month period. So you only need two in order to meet the mild form of the substance use disorder. And again, that 12-month period is something to pay attention to as well. So we're keeping substance use taken in larger amounts over a longer period than intended. So that shows that lack of control, that there's a desire to and unsuccessful efforts to cut down or control use. So again, evidence that the person isn't completely in control of the decisions that they're making. A great deal of time spent in activities to obtain the substance or recover from its effects, and this is the new criteria: craving or strong desire or urge to use the substance. And I'm going to also hand this over for Kevin to make some comments about this, because I personally think that this is the most significant advancement probably in our ability to describe and think about substance use disorder for people, and to be able to describe what we're doing in order to treat the substance use disorder by keeping by being able to assess and keep a handle on how strong that desire or urge to use is for people, where that craving is. And so I think that this will add to our understanding of what's happening, particularly for people early on in the treatment process. So.
Just some thoughts on craving. One is, why do they add this kind of thing in? And again, part of this came from brain research in terms of when they can. You may have saw people, brain scans of people when they were showing them pictures of, say, a nice, pleasant nature film, and a certain part of the brain might have been hyperactivated, specifically the amygdala, especially. And then they showed them a recovering person with, like we said, Al Pacino in Scarface with the 50 pounds of cocaine on his desk there. And for people who are cocaine addicted, all of a sudden you saw the amygdala super fire up. It was like a blowtorch effect, just by that stimulation image. And those of you who work in the field, you've seen people like this have this incredible craving, almost like that look in their eye, if you will. Why do we even have war stories? Sometimes we talk about the idea of war stories, and we don't have any war stories told in certain settings, because when people start talking about it, you see this almost a hijacking of their brain, if you will, of they start getting really excited, they start getting animated, sometimes even agitated when they talk about copying that good stuff they had and so forth. And you can just see almost a hyperactivation of their brain going on. And that's been recognized as, and then of course we say, well, how do you talk them down from that? Otherwise they're going to go out and use. And so that's not in your head figuratively. That's been really shown to be in your head sometimes literally in terms of changes neurologically. From the point of view of working with patients, we do assessments, and do we think about that yet? So if this is one of the criteria, are we going to be asking folks, and those of you who work in agencies, you have forms, do they have that on their forms? Do you have cravings for these drugs? My prediction is we're going to have some tools to help measure that. There are some research tools around measuring a craving of specific drugs. I've been looking around for craving measures since this was coming around, and maybe you folks out there know some better ones, because Lord knows I would like to find some, where I saw some for specifically like for cannabis craving and cocaine craving, and it was developed as part of a research study that NIDA funded for cocaine treatment. So they wanted to measure, before and after kinds of things. And so, we're going to have this conversation with our clients as we go along. And one thing I would have us especially think about, and it's going to be interesting to see how insurance works with this. So I oversaw a number of outpatient treatment programs, and those who work in outpatient 822s, you know that sometimes they're in there for a while, maybe 5 sessions, 10 sessions, and if they have private insurance, Medicaid managed care perhaps, the insurance company after a while calls you up and says, well, what's the justification to keep this person in treatment? Why do they continue to need treatment beyond these X number of sessions? Well, if craving is one of the indicators of the disorder, it would be important for us perhaps to be measuring this craving and saying, well, they still have cravings or they do not. But the idea here is this is one of the symptoms of this disorder. So in the absence of tools around that, I think it's simple, at least for us, to simply to have a conversation with our patients and go, you still have desires to use, and let's start using numbers on a scale of 1 to 5 and a scale of 1 to 10. How strong are these cravings? You might find, by the way, and I found this, sometimes the most together clients sometimes are still reporting strong cravings when you ask. Wow, you seem to be doing well, but they go, yeah, but I still want to really get high. And sometimes that's not obvious until we ask the question. So I think this might be a useful kind of thing in that context as well. Another thought on this is a number of the addiction medications that are, and I predict will be developed as well, are really targeted and sometimes even marketed as anti-craving medications. And so this might help us in terms of decision making about which individuals might be better suited for medication-assisted therapies as well. Those who are not doing well, they report strong cravings, well, there are various medications that target that. And so that might behoove us to think more in that direction as well. Those are my thoughts on cravings. So, Pat, you want to continue along? You want me to go on?
Well, why don't I just finish up
Sure.
and just say one more thing in terms of stabilizing patients as well. Craving and strong desires to urge can last for a very long time through a person's recovery process, and the DSM-5 even suggests that you can be in remission while you're still meeting this criteria, so that you're expected to have some of this over the time over a period of recovery. But people who have cravings that are so strong that they're unable to really, be able to stop using, it isn't something to be considered for stabilizing a patient before, expecting them to kind of move on into the recovery process. So that's my only other thought about that. The recurrent substance use resulting in failure to fulfill a major role, again, that's the same. Continued use despite persistent or recurrent social or interpersonal problems, that is carried over from the DSM-4 as well. And then, these concepts of, important social, occupational, or recreational activities given up and use in situations where it's physically hazardous. So a lot of the criteria are very much the same. You'll find that one is missing, and I think that, so substance use is continued despite knowledge of a problem is also there, and the need for markedly increased amounts to achieve the intoxication or desired effect, so that is tolerance, and the markedly diminished effect, also tolerance. And then withdrawal, the characteristic withdrawal syndrome for the substance or the same or closely related substances taken to alleviate that. So as I kind of foreshadowed, there's a problem indicator that is in the DSM-4 that's not in DSM-5, and that is legal problems. So that's significant for us to think about, because oftentimes people are referred to treatment because of a legal problem, and oftentimes that chief presenting problem was one of the indicators that a person was in need of treatment. So that is no longer in the DSM-5, and I don't know if you wanted to say something additional about that.
Just a few thoughts. One, I think people ask, well, why? Gee, I know I met people, certainly interviewed people where, man, you saw them having legal problems that were really related to, that seemed to be related to their alcohol, drug use, etc. So he or she gets drunk, then they get in fights.
Yeah.
And that's when they get drunk and they get in fights. And you say, drugs relate to legal problems. I think one of the challenges they had is that this was not easily, it wasn't, if you will, fairly distributed. So the example I give now is, imagine you're walking down the street in Georgia with marijuana cigarettes, and then you're in Colorado. Will the legal system treat you differently? All right, in terms of how they look at you? The answer could be yes, right? But does it tell us anything about whether that person has a cannabis disorder or not? It doesn't necessarily, right? What has happened is the environment has changed as opposed to simply, so I think that was one of the concerns about these kinds of things in terms of just the environments, and this is probably more of an issue as we go along in terms of certain drugs, especially cannabis, obviously being tolerated. So I think that's some of the thinking that went into this. That said, though, I think it makes it more difficult. And now, those of you who do, I always say, if you do DWI assessments, you know about this right away, because very often you have people who are really playing down for various reasons the nature of their problem. They're sometimes bald-faced lying to you, if you will, at times, and which is why we have a whole protocol for DWI assessments, which does include just talking to the patient, right? Toxicologies, get the driving record, look at the arrest, do an SO interview, etc. But I think it's going to be much more difficult, especially in light also of you have to get don't forget two symptom sets before we diagnose someone to need treatment. Just some thoughts on that as well. So what if you have somebody with one symptom? Well, what they're saying, they're not eligible for treatment. That does not mean they're not eligible for an intervention. Right. And one of the things I think it might behoove us to learn more about in our outpatient programs especially is the idea of doing brief interventions with patients. So someone comes in for an assessment, you see an indicator perhaps of dysfunction, that's all you can see. Well, maybe we can do a brief intervention with that person even though we cannot admit them to treatment. I would suggest to you, by the way, the DDP programs are exactly that as well. They are for people who have an indicator of perhaps a problem, and they do an intervention, which is, well, some will say brief, most of the people who go for it don't think they're brief, for a certain number of hours educationally with them, with the idea of, well, we know if you have a diagnosable problem in need of treatment, and by the way, if you get screened positive, we will send you a program to see if that is, but it's the idea of doing something with somebody. But I am concerned, I think as most of the people in the field, as we're going to be really underdiagnosing certain individuals possibly. We're going to have to let them get into more trouble, if you will, before, and that has implications for who gets provided service and how we go about doing it. Those are my thoughts on that.
Yeah, just two quick additional ones, and then I'll hand it to you to talk about the differences in remission. But if just a little bit of a preview to the locator, which we should have out in field testing during the summer, is that exactly what Kevin was talking about. If you have only one symptom, it's going to ask for the symptoms, that are met for a DSM SUD diagnosis. That if there's only one symptom that's met, the recommendation is to consider a brief intervention. And we, through the APG process, there is the ability to, and regulatory process, there is the ability for an outpatient clinic to consider that. Also, I think that by removing legal problems, it really kind of forces clinicians to think about the health nature of the addiction. That and very often legal problems are driving some of the other kinds of criteria. It's a matter of really looking at the addictive process for the person. So I think that actually clinicians and clients will be able to adjust to this, and people will get the treatment that they need.
Okay. So going on to remission criteria, the way it's changed, and by the way, Pat went through those remission criteria, the DSM-4 fairly quickly. You noticed there was quite a few of them. There was 4 early, full, partial, etc. My experience is most clinicians, their eyes glazed over when they looked at those kinds of things, and I think that was the problem, if you will, and why they wanted to change it. The other comment I would make, by the way, about remission is that I put it as it's a harm reduction model. You notice what it says now and actually in 4 is once the person meets the criteria, they no longer have symptoms of the disorder. You notice it doesn't say they're abstinent. And so in the treatment program, sometimes they say they're remission, and it's they're abstinent means they're in remission, and the DSM doesn't look at it that way. It hasn't looked at it that way at all. So I found abstinence-oriented kinds of facilities and programs and philosophies, if you will, really were struggling with this words in the DSM called remission. Gee, Kevin has had 3 positive toxins in the last 2 months, but he hasn't had any problems, so he's in remission. Mm-hmm. And by the way, is the judge who sent them there going to understand what remission means as well? Do you have to explain that to the judge as well? Remission does not necessarily mean abstinence. So the DSM-5 has not walked away from that perspective of the person. If they have the diagnosis, or do they have any symptoms, they're in remission. And again, think of that again from a point of view of medical treatment, where people can have various diagnoses, but they don't have any symptoms. They're not manifesting anything. It's what's the problem, right? So people can have diabetes, but in remission, if you will, even though they might be still diagnosed in diabetes, cancer. You can have that. And so it's the same mentality here. Now, what they did with this, though, is you had 1 and 12 months early fall. So what they did is they simplified it somewhat, and they said early remission from a period of 3 to 12 months, you don't have any symptoms except craving. Again, craving, as Pat mentioned, is something that's seen an on-off kind of thing, and it can be through your lifetime. I always say, have you noticed in certain communities they have 12-step 24-hour marathons during Thanksgiving and Christmas time? And why do they have those kinds of things? There's an understanding that some folks really can have these cravings anytime, and sometimes you see some of the folks you haven't seen in a long time in those meetings end up showing up around those holidays. And it's just the idea of sometimes this will happen even when you have no other symptoms. So early remission is 3 to 12 months. You don't have any criteria except possibly craving. And in sustained remission is the same premise, but 12 months or more. No symptoms except possibly craving. Now, an interesting thing, how is this going to play out perhaps, is how do we decide if some people are on medication management forever or part-time, or partial, for a limited time, I should say. Because what we're saying is you can have cravings for 20 years, 30 years. Mm-hmm. Therefore, should you be on medication management for that? I think that's an issue to be played out still. I don't know how that's going to play out in terms of this. We still have, though, as well, the specifiers around controlled environment. Again, that's typically residential programs or incarcerations. And the word they used to have is agonist therapy. Now they use the word maintenance therapy with this, because some of these things may not be agonists, actually, or maybe partial agonists, whatever language we may want to use around this. So as Pat already alluded to, the idea of severity scale, so the person, you interview them and they meet no criteria 1, that is not a treatable, from a point of view of a Oasas licensed treatment program kind of admission criteria. Again, you might want to do some interventions with that person, but that's not a treatment candidate. 2 to 3 criteria, you have a mild substance use disorder. 4 to 5, moderate, and 6 plus severe. I'll give you an example of how this plays out in language. So I had somebody in our outpatient clinic. This guy had 1 lung left smoking crack, but he was working. And so he basically had 3 symptom sets in DSM-4 criteria. So I can talk to him and also his insurance company as he has cocaine dependency. Now, with the DSM-5, I will have to talk to him and his insurance company and see if he has what? A mild cocaine use disorder. Now, that, just from the point of view of the person hearing that, but also think about this from the phenomenon of working with insurers who may not be understanding of some of the specific symptoms, that really might play a different dynamic with those parties. Again, we will see how this plays out, but the language is important sometimes. If I tell somebody they have a mild problem, are you as worried if I tell you have a moderate or severe? And again, this is where language, we will see how this plays out. in review. So this is kind of a quick review of some of the things with DSM-5. Abuse and dependency, say goodbye to, and we combine them. But also legal problems have been removed. Craving has been added. And we need that criteria of 2. So I think what's going to be happening is perhaps under identification, we're not going to be identifying certain kinds of individuals. And I think the clinician is going to say, wow, I got to get at least 2 here. And it's going to be like a fishing expedition. You want to get those bites for at least 2. Now, to be honest, I think we had that sometimes in treatment programs with 1 even. So I think this system mentality is going to be, though, let's get at least 2 here. And we'll again see how this plays out. And the physiological specifier is gone. If we have withdrawal symptoms, you have specific withdrawal symptoms to various substances around that. You want to talk about the different categories with me too?
No, go ahead.
Okay, so now there's just some slight differences from DSM-4. The categories that have of drugs is alcohol, caffeine, cannabis, hallucinogens. Now, one thing is PCP, angel dust. What we call typically angel dust, phencyclidine hydrochloride, is now, that had its own category. So now they decided it's an hallucinogen. Now those of you who work with, I worked with a lot of PCP users back in the day, and we used to call it an inside-outer. It's an upper, a downer, a hallucinogen, it's an anesthetic primarily, by the way. But they decided to classify it as an hallucinogen, and so it's inside of there. Another issue that comes up is, what about the cousins of these various drugs? So special K, ketamine, is I won't say an analog, but it's a very similar kind of acting drug. I don't know if you're going to say that's an hallucinogen as well. I think that's a kind of a controversy that'll go around, and I wouldn't be surprised if sometimes people doing special K ketamine will be called hallucinogen disorder, and we'll get to that about how you work with that, or else other disorder, because this drug is just another category, if you will. Other categories: inhalant use disorder, opioid. We still have sedative, hypnotic, and anxiolytic. I always love that phrase because usually in our field I don't hear people talking anxiolytic, but think of anti-anxiety drug for the most part here. Stimulant use. Now we used to have, includes cocaine. Now we used to have separate cocaine use disorder and stimulant use disorder. They decided, again, to put cocaine inside of stimulant use, and then you have tobacco use disorder, and then you have other. Now, I found the interesting thing is we don't consider caffeine a stimulant. Why didn't we put caffeine inside of stimulant use disorder? And also tobacco, the active drug that we see primarily is nicotine, right? That's a stimulant drug, but we decided not to put that into stimulant use disorder. I do not understand the thinking behind this, but it is what it is. Now, other and unknown is the one I think we might find ourselves more frequently diagnosing people with sometimes when we start getting people using these various, we might use the phrase black market drugs, the analogs, etc. So we got people now coming with what? K2 and spice. Now, if the person, so how's that been represented as? It's a cannabis analog, if that's what it is. But you don't know, and that person who's usually smoking that stuff doesn't have a lab analysis of this. They don't know what it is either. So we believe that when people are taking this stuff, this is known as K2 spice, and now it has a dozen other names as well besides K2 spice, that most of these things are cannabis analogs. So the diagnostician has to decide if they want to put this under cannabis use disorder, right, or other substance use disorder. Either way, by the way, we're going to get to this. Always specify the specific drug you've identified, because there's such a range inside of these categories that we really should be doing this. But then, of course, we're going to have these other drugs that are really coming down the highway of, I would say to people, go on the internet, you can find these really funky names, things like 2CB, and just letters and names after them, and they're on the internet, and what the categorization of them is really unknown, since some of these are very experimental drugs. Go to Europe, and they're doing all sorts of interesting psychonaut kind of stuff with this stuff, in terms of people doing their trip reports on just variations of chemicals, they're putting them online. And if a person came to me using this stuff, I'd say, I have no idea what this is. And so that's where I think the idea of other or unknown is going to be coming in. Unknown is also, by the way, a common ER kind of one. When someone comes in overdosing, we can't identify what's going on. We don't know what the heck they took. They can't talk to us. No one's telling us. That's where unknown sometimes legitimizes the admission into treatment. But as I was just alluding to, use the specific drug in the diagnosis. So someone if the specific drug we're identifying as cocaine, don't say mild stimulant use disorder, say mild cocaine use disorder. By the way, in terms of some of the coding, like 30560, the abuse typically of the category matched up to the mild version of that. And then the dependency of that category typically matched up to the moderate and severe of that category. But you have to look at specific
numbers for some of these things were overlapping, so amphetamine and cocaine were different numbers in the DSM-4. So you're really going to have to keep bone up on that. Some of this will be the same, and some of these will be variations. So when someone has doing OxyContin, you really want to identify, especially in that kind of category, the opiate they're using, because if someone's using heroin as opposed to OxyContin, and I'm seeing, for instance, they have needle marks on their arms, well, that doesn't sound like this, then they're just using OxyContin, unless they're injecting OxyContin, does it? So I might be looking much more at that point for heroin or injecting of other drugs as well. So that's the idea of specificity when we do the drugs, even in the diagnosis, just for those kinds of reasons. And again, I already alluded to the idea of these other unknowns, these various other kinds of things that are out there. Some of you are right now going, what's Kevin, what's betel nut, what's kava? Look it up, as some of our teenagers already, I predict. And some are over-the-counter drugs, and some of the ones that we might, in traditional substance abuse programs, not deal with as much. Anabolic steroids, maybe NCAA, people work with NCAA athletes, they test for that, and they may have to deal with those kinds of things. And again, you can't even figure out what the heck it is. Those are the new black market drugs, and I think we're going to be seeing more and more of those as we go along. This is getting in summation. The remission descriptors has changed only two possibilities, and again, craving doesn't affect that, so you got to keep that in mind. Craving is seen as this ongoing, lifelong possibility. And then we have some new substance-specific diagnoses: caffeine withdrawal. Oh boy, some of you are giggling already, I bet you. And cannabis withdrawal, which has really been, I think, a kind of, when I talk about this, a bunch of people say, really? And so that's, I think, one's going to be kind of controversial around this. You want me to talk about it?
Go ahead.
Yeah, so cannabis withdrawal. So the idea here is that they've identified, when I say they, the American Psychiatric Association has recognized, based on research, and this has been going on for quite a while, I've been kind of tracking this, that there's a certain subgroup of people who smoke heavily, marijuana, and when they stop, they go through what seems to be withdrawal-like symptoms. This may explain some of the people you have met, either as patients or people in your life. They keep smoking that weed, right? They keep on using. And now if I asked you, what would happen to them if they stopped? What kind of things? What I found when I asked groups of this, a bunch of people seem to have the same symptom sets they recognize, even though they're struggling with the idea of withdrawal. Now, what the DSM-5 says is a characteristic of withdrawal is, first of all, you're going through withdrawal after you've been using heavily and for an ongoing basis, and they use the phrase almost daily or almost daily over a period of at least a month. They don't give you dose levels, by the way, so I always say, well, how much marijuana? And I think they were reluctant to do that because two marijuana cigarettes in one neighborhood is different than two marijuana cigarettes in another part of the state or the neighborhoods. I always talk about Brooklyn blunts, and as I'm down in New York City, everybody starts laughing about that may be one cigarette in Brooklyn, but it's maybe five in another neighborhood. So I think that's why they were reluctant to talk about specific amounts like that. And so, but after a person stops using, and again, usually after several days, 3 or more signs within, and they use the word 1 week after this. One is irritable. So you see somebody stop smoking. Are they irritable, angry, and just kind of nasty all around, or more nasty than usual, perhaps? Anxious, nervousness, sleep difficulty. They can't sleep. They kept on getting up and down. The dreams are abnormal types for them. Decreased appetite or weight loss. One thing we know about marijuana, by the way, is it stimulates a particular part of the brain, which is why people have the legendary marijuana munchies, right? So now they don't have that level of stimulation. Restlessness, depression, and they have also a physiological, you're looking at it for a physiological indicator, and they talked about abdominal pain, shakiness, tremors, sweating, fever, chills, or headache. But to the point of clinically significant impairment. Again, you got to have a problem for us to say you have these things. And make sure, and this is where the problem is, because you have these things, you have some sort of area of functioning. Now, are folks going to need detoxes inpatient? I have never sent anybody to a detox for cannabis withdrawal inpatient, but I don't know. Now you have the ability to bill, I would assume, because it's a recognized disorder. So the question is do we have to go put people through an outpatient taper or whatever? I don't know. We might have medications, for instance, specifically around that. We have medications now by prescription, and so, and actually they're looking at various mists and fluid versions of THC content medication. So perhaps these might be used. I don't know. This is something to be played out as well.
Again, and just rule out other reasons for you to have this. So to be continued, and I already saw one medication they're already trying for to manage withdrawal. Again, this is a perfect example of how pharmaceutical development follows diagnoses. So sometimes there's medications that are already out there that they know of, and maybe they can use them in other contexts. To be continued on that kind of issues. Again, the summation idea is in terms of categories: cocaine, there you go into stimulant use disorders, but not our friends caffeine and nicotine, even though they are stimulants. And again, PCP/angel dust has been put into the hallucinogen family. Just to make the point, we talk about substance use disorders, but just to make the point, DSM has a whole bunch of other kinds of what we might call mental health symptoms that are specifically induced by the drugs of various drugs of abuse. And my experience is I never really see many clinicians diagnose people coming in with these substance-induced disorders, even though I think in certain settings you really see these things. So you get in recovery. How you sleeping? I'm not doing really well. Well, this may have been a substance-induced sleep disorder. If we have the conversation around sexuality and sexual functioning, how you doing with that? This might have been a substance-induced sexual problem, and anxiety disorder, etc. My experience is just that we say, well, the drugs are doing that to you, and that's it, and you just stop using drugs, and these things will go away. And that might be true, by the way, but I think we're very reluctant to throw these other diagnoses, for better or worse, in terms of does that treat what's there or not. But it's an ongoing kind of issue I've seen around this issue around diagnosing. And of course, the idea here is also, in terms of overall way of looking at addiction, is that this category of substance, what we had in DSM-4 as a substance-related disorder, has now been subsumed, along with gambling, into addictive disorders. And that's in anticipation, it seems, that we're going to find other addictions, if you will, that might meet DSM criteria, DSM 5.5 or DSM 6 or whatever, and you'll have some similar dynamics because of how it plays out in the brain in terms of symptom expression will be similar, even though it may be not drug-driven as opposed to gambling-driven, but it'll manifest with certain similarities around this. All right, so I believe we have some time, so we can actually do some sample cases around this. And this is the idea of simply given this, this idea of here are the symptoms, what criteria might people have? And this is, I find, as is all DSM, my experience, sometimes very subjective. Because what do they give you enough symptoms? Is this really a pattern of use? I find the word pattern, which is in the DSM right there. People say, well, is this a pattern? We do it once. Well, I know sometimes they probably haven't told me, or they just haven't been caught. The DWIs, you get this. So the person always says, this is my first time I'm driving drunk, right? And statistically, we know that when they do studies, that typically that's not true. They probably had driven drunk before. They just never were caught. So he's saying, well, they do have a pattern or not. It's the reporting makes this very kind of iffy and really, I think, gray. So just for, I kind of say for fun and suffering, let's look at some sample cases and see if we would diagnose this person a certain way. So I'll read it to you out loud. So this client was referred to you by probation following conviction for cocaine possession. And this person was arrested also for cocaine possession in September 2010, but says, I got no other problems in that period with cocaine. They also crashed their car while driving drunk recently in February 2004. And his family is worried that they might get in more trouble. And you haven't seen any other drug or alcohol-related problems. So you're looking at that symptom set. And all right, what problems do we have here? And my experience with clinicians is they go, wow, this guy got driving drunk, he got cocaine possession, and so forth. Wow. And if you're like a good bloodhound, you say, where does smoke, there's fire, perhaps. And a lot of times they lowball you and so forth. And so the temptation is, they got some symptoms there, right? So what are the possible diagnoses around that? I almost wish we can kind of stop and go, all right, 5 minutes, discuss amongst yourselves, but we can't do that. I would suggest right now, given just that information you have,
have, there's no diagnosis yet. Now, you're sniffing it and going, wait a minute, this guy may have a cocaine use problem because that's all they've been told, I've been told so far. I mean, you're right. So we would have to rule that out. And of course, ditto for the alcohol use problem. But what is the pattern of use that leads to our impairment? You see an incidence of use. Let's go back to it, actually. So he was arrested for cocaine possession, which, by the way, might mean he's a drug dealer as opposed to a drug user. And I think that's one of the things we see sometimes is we end up with drug dealers who tell the judge, of course, they're drug users, and that's why they need to go to your treatment program. But DSM is saying a pattern of use that leads to our problem. And again, you have the person crashing your car. Wow, that might be indication of a problem, but this is a single incident so far. So yeah, like a good bloodhound, you're saying this possibly, but you need to go more. And that's why we don't just, based on a few sentences of information, we make diagnoses. That's why we need to do an assessment. That's why we want to get collaterals. That's why we want to do toxicology testing and so forth. Because, man, you might be right. They might have a stimulant use disorder or an alcohol use disorder or a lot more than that, right? But right now, that's what we have with the DSM.
And I think just to say here that this is, even though you may have 0 and not even a 1 on the diagnostic criteria, there is high risk use going on here very clearly, and that is, I think, an opportunity to spend a few brief intervention sessions. And sometimes, if there is something more there in the brief intervention, particularly, a really skilled clinician can find out more information, by not just telling the person what to do, but really eliciting from them any concern. So that's an opportunity, I think, to continue to keep somebody engaged that clearly has a high risk.
Yeah, I agree, especially after a while they're spending time with you and they see that you're okay, you have good clinical skills, there's a therapeutic bond forming, and you maintain confidentiality. Something maybe I do have, it enlarges the conversation. And by the way, of course, you may be doing toxicology at the same time, and some other truth may come out as well during that period. Let's go to the next one. So this person, or a younger person. So this person's an 18-year-old referred for heavy pot smoking, whatever that means, right? He's in senior year of high school and has not been attending school. Some other things, this is due to the combination. I find this with adolescents all the time, by the way, the bad friends. Jimmy's friends are dragging him down. And his marijuana use, which makes him forgetful, lazy, unmotivated. It sounds like marijuana, we used to call them amotivational syndrome with marijuana, right? He's lost 2 part-time jobs in the past year for not showing up to work. He misses smoking a lot when he's vague on frequency, though he's vague on the frequency because, hey, it depends on when I get it, I smoke it. He can do a few joints a day, he says, and really function fine. He really intends to only smoke on special occasions, but, when the opportunity is to use it, hey, I'm going to smoke it. All right, so question, what's the diagnosis here? Again, I'd like to stop us for 10 minutes and discuss amongst yourselves, but we can't do that. What do you see here? Well, some people say, well, he lost some jobs there. Somebody saying smoking pot. He's doing some joints and he can function okay. There's various kinds of things. So I would suggest right now he has at least some indicators of a cannabis use disorder, mild version, and he might have more, again, depending on further interviewing with him. The specific ones, and which specific ones you think might be there is, I wouldn't say he lost 2 part-time jobs, by the way, because I find teenagers sometimes, they just are impulsive, and he wanted to go to a Drake concert and he just didn't show up for work and he got fired. So there's all these different kinds of things with kids, I find, a lot of times that go into this. The thing that I found is he can do a few joints a day, he says, and really function okay. That suggests to me tolerance, and that to me is an indicator. And he intends to only smoke on special occasions, but finally when his friends are there, he uses. That's a loss of control indicator to me. So based on that right there, I would suggest that he might have 2 indicators. Now again, I think some people watching this may say yes, but. And again, that's where I think there's some subjectivity around these kinds of things. And if you're in a setting like that, this is why we have things like what? Case conferences, clinical supervision, etc., to do these kinds of, have these kinds of conversations. Just another scenario, client's referred to you by his wife, who's very concerned about his cocaine and alcohol use. You verified he's using cocaine 1 to 2 a week, with the use varying from 4 hours to occasional 3-day runs. You all know what runs is, right? They just keep on going. When he ends up missing a day at work as well. This has gone on for over a year now, 14 months now. And the client shares with you that he's really trying to slow down at times, but he finds that he fails. Notice he didn't say stop, right? He's going to slow down. And he's frustrated that, I only want to do a few lines there, but and I end up going off to the races. I cop a gram, and that's for Friday night. It's going to last me to Saturday night. By 1 a.m. Saturday, back there getting it, etc. And he drinks when he comes off the cocaine to ease the crash, and sometimes he'll just drink, quote unquote. That's what he says. Again, what are the indicators here? What are we kind of seeing around this? I would suggest, one, he's given me some indicators of mild cocaine use. Again, we're further interviewing, further information gathering. You might have more moderate or severe. And simply because he talked about drinking, and it's so commonly coupled with stimulant use to bring you down, take off the edge of the anxiety feeling. You also certainly want to consider also alcohol use disorders. The specific things I looked up here is he's not showing up at work sometimes. So in terms of his occupational obligations are being impaired with. And he himself has said, I'm really trying to do something to slow down. You obviously would want to know what that is. Maybe he's telling you, hold my money, don't don't give me it all at once. I'm not going to Freddie's house because when I'm with Freddie, he's got a lot of coke. I'm not going to do that. That's his recovery plan, right? And that doesn't help. But he's got at least two indicators that would suggest to me amongst that. Just watching the time right now, I think we only have 2 or 3 minutes, so I'm trying to think. I'm going to throw it back to Pat whether she knows about not about summing up anything you can think of.
Yeah, no, I think I like the idea that we had a chance to at least think about some clinical vignettes, because that's the kind of thinking that I think people are going to be requested to do, that to really be able to substantiate what supports the diagnosis. And as managed care becomes more prevalent in across the board, I think that when you can make those kind of distinctions, when you're really thinking critically about these things, and while there's gray area, there certainly is a clinical justification that you have to make. And so I like the way that you did that, and I really appreciate you being able to come and spend the time that you did going through this. I think that we really appreciate that.
Thank you. I'm sure there's probably some disagreements even with some of the things I said here, and that's what's going to go on in this field. As the DSM-5 comes out, we're just going to see interpretations and what does that mean, and it's just going to evolve. Yeah. It's just going to evolve, and not only based on our own subjective things, but as managed care tells us things, as perhaps Oasas gives us guidance, as the field develops even nationally, we're going to get some further clarifications, perhaps. We'll see.
Yep. Well, I think that with any new iteration of the DSM, it comes with all of these kind of questions. And, I think a couple times you've said we'll have to see how it plays itself out. And I think that, there's a lot of truth to that in practice, the application of this, there's a lot to learn from.
Okay, I think with that, we thank you all for listening and for attending this webinar. And there's my email, and Pat's there, and you can contact us that way.
Great.
And that concludes our presentation, the DSM-5 changes, what the addiction professional needs to know. Thank you, Kevin and Pat, for your time and expertise today. Again, don't forget to fill out our evaluation. And if you have any questions regarding Learning Thursdays, please send us an email to learningthurs@oasas.ny.gov. Thank you and have a wonderful day.